Okay, there is no stem basically. Yeah. So in this case, they will give you this
Yeah.
stem. Okay. A 60-year-old man presented
Yeah.
with an enterocutaneous fistula following a surgical resection and radiotherapy for a colonic malignancy.
Mm.
Now, define enterocutaneous fistula.
So intercutaneous fistula is the abnormal connection between the skin and enteric cavity, GI tract, which is lined by the abnormal granulation tissue.
Excellent. What causes an enterocutaneous fistula?
Okay, so the causes might be the infect preservation factors, infection. Okay, so infection, inflammatory bowel disease, sepsis, and foreign body, and radiation, and any neoplasms in neoplasms.
Okay, so all right. They ask you what are the causes of enterocutaneous fistula. You can mention all those things, but just mention 75% of enterocutaneous fistula are the complication of abdominal surgery. Correct. So now tell me
Yes, sir.
about the classification of enterocutaneous fistula.
Okay, so it is classified into external or internal, simple or complex, and congenital or acquired, and also anatomical and physiological.
And also high output and low output. Correct.
Yes, sir. In physiological, it is high output and low output. In anatomical, it is enterocutaneous fistula, enterocolic fistula, colovesical, vaginal.
Very good. Now tell me the high output fistula, moderate output fistula, low output fistula. Okay, if you don't know the answer, okay, this was my station in the exam. They
I will
didn't
come
ask me
back.
this thing, okay? All right.
Yes,
So
sir.
they didn't ask me this question. I'm asking you just for the, for the that you may, yeah, they may ask you like, but just know the higher fistula is more than 500 ml, okay, per 24 hour.
Yes.
Moderate is 2 to 500 ml, and low output is less than 200 ml. So the predisposing factor. Can you tell me the predisposing factor of the enterocutaneous fistula?
Yes, sir. Foreign bodies, radiation, inflammatory bowel disease, and neoplasm, and distal obstruction, and sepsis.
Very good,
Friends.
excellent. What are the complications of the enterocutaneous fistula?
Hello.
Yeah, can you hear me, Dr. Prabhat?
Yes, sir.
Yeah, Dr. Prabhat, can you hear me?
Okay, so there will be fluid and electrolyte balance. Patient will be malnutrited. Yes, sir. Yes, sir. I can hear you. I'm answering. Is it? Am I audible?
I can hear
Yes,
you.
sir. Am
Go
I
ahead.
audible?
You're audible.
Hello.
Yeah, you audible. Both are audible.
Okay. I guess sorry is not listening. My
I am listening.
okay.
Dr. Prabhat, just
So
go
the
ahead.
complication would be electrolyte. Okay. Okay. So the complication would be fluid and electrolyte imbalance. Patient would be malnutrition. There will be malnutrition and sepsis, and skin will be excoriated outside.
Okay, other than this, okay, I was answering the same thing what you just mentioned. He wants further something else as well, okay? So remember,
Hello.
yeah,
I
re-
think the connection is not stable.
okay, just listen. The examiner wants something else beside what you have mentioned. Okay, you mentioned sepsis, malabsorption, fluid and electrolyte imbalance, the skin problem or skin excoriation, the psychological disturbance. Also mentioned the loss of
Okay.
the alkaline pancreatic juices, which may cause metabolic acidosis. All right, and hypoalbuminemia can cause increase on cardiac pressure and edema. Just remember this, okay? Now, can you hear me, Dr. Sultana?
Okay, sir.
So now tell me, what brings the patient to the operation theater within 24 hours?
Excuse me, can you please repeat again?
What brings the patient to the OR within 24 hours?
Okay. Oh, yes. So there might be intra-abdominal collection, abscess or sepsis, and also due to distal obstruction, there might be swelling in intra-abdominal.
Okay. What are the signs of intra-abdominal sepsis?
Okay. So there will be abscess in the abdomen, and patient will be tachycardic and hypotensive, as in septic, and there will be nausea and vomiting and fever.
Yeah, which kind of fever? Swinging pyrexia, correct? All right.
Oh, yeah, yeah. So
Yeah, yeah. Now tell me, what is the management of this patient?
okay, so I will manage the patient according to the care of critically ill surgical patient protocol, following the ABCDE approach. First of all, I would like to administer the fluid and electrolyte. I would like to manage the patient fluids and electrolyte balance and control the sepsis of the patient. And for nutritional support, I would like to administer total parenteral nutrition. And I will do the anatomical assessment of the fistula, where anatomical assessment, and then plan surgery accordingly. And also, I will protect the skin.
Okay. So you mentioned about this. Uh,
Yes, sir.
will you go for any investigation for the anatomy of the fistula?
Hello.
Yeah. Can you hear me, Doctor Rabat?
Okay, sir.
Now, can you hear me? What are the investigation you will like to go for this patient?
Clearly?
You audible.
Yeah, source
Yes,
network is, yeah.
bad. I
I
think
was
so.
double, triple checking my internet connection.
No, no, the problem is in my internet connection. Okay, I know this very well. So just go ahead and tell me the investigations.
Yes, sir. Yes.
Yes, sir.
Okay, sir. So I will do a CT abdomen pelvis with contrast and fistulogram to
Okay.
delineate the anatomy extent. And if there is any distal obstruction, then fistulogram would be both therapeutic and diagnostic.
All right. So, what is the indication of surgical management in this case?
Surgical management indication.
Okay, we'll come back to this question because this is a new question. Okay. Why this is a new question? Because they asked me
Yes,
this
sir.
question and I don't know the answer at that time. So, just consider it that this is a new question.
Yeah.
Okay. They asked me. Now, uh, tell me about the factors preventing the spontaneous healing of the fistula.
Okay, so first of all, if there is distal obstruction to the fistula, and if the patient is malnutrited, and if there is any sepsis, ongoing infection, and also history of inflammatory bowel disease, or if the patient has undergone radiation therapy, then the fistula might take time to heal.
Okay, more than enough. All right. Tell me about the fistulogram will tell you what.
About the length, if there is any distal obstruction or not, and location.
Yeah, the location of the
Location.
fistula, distal obstruction. Then, now tell me, uh, if suppose the patient is having high output fistula, then what are the kilocalories
Yes, sir.
requirement in that case, and what is the normal person kilocalorie requirements daily?
So for high output fistula, we need more. Normal is around 20. around 30 kilocalorie per day, and patient will need around 40, around 50 kilocalorie per day.
Okay, for the normal person, 25 to 30 kilocalorie per kg per day. For the high output fistula, 45 to 55 kilocalorie per kg per day. Now, I'll ask you a few new questions.
Okay.
Okay,
Yes.
why will the patient ABG show metabolic acidosis in this case?
Okay. So, is there might be intraabdominal collection or infection? There would be anaerobic oxidation and release of lactate, which increases the acidic amount and causes metabolic acidosis.
Also, if there is a loss of alkaline pancreatic enzymes or juices, that will lead to
So
metabolic
also loss of,
acidosis, correct?
yes,
Yeah, good.
bicarbonate.
Now
Yes,
tell
sir.
me, the blood results of this patient shows low sodium, low
Yes,
potassium, okay, and
yes.
low bicarbonate. So why is this? And they ask me this question. They show me the investigations of the patient, okay.
So maybe the patient is having a rectal high output fistula.
Yeah, maybe it's because of the loss of pancreatic juices. Maybe it's because of the septic causes like lactic acidosis, which you mentioned previously, okay, which will lead to low
Yes.
bicarbonate. Why is bicarbonate, where is bicarbonate mainly produced from?
Um,
Okay, so the question was about where would we?
bicarbonate. I think it's
Okay,
pancreas
yeah,
or
that was a new
the,
question that we were discussing. If they ask you,
yeah, yeah.
uh, where is bicarbonate mainly released from, you will tell him the pancreas and also from the bile, from the ileum, and from the saliva. Okay. Now,
Okay, sir.
what is the surgical management? Remember, they asked me what is the indication of surgery. All right. So, the
Yes,
indication
sir.
of surgery is that we usually do a trial of conservative management. 60% of the fistula will close spontaneously when the sepsis is controlled and the distal obstruction is relieved. Surgical management is usually required if there is sepsis, okay? If there is peritonitis, sepsis, all right? Or if there is any
Okay,
complications. These are the indication for the surgical management, okay?
okay.
So
So
the
the conservative
peritonitis,
management. Yeah.
yeah, peritonitis and sepsis, you will mention those two words. These are the indication for
Okay.
surgery. Now they will ask you in surgery what you will do.
Yes, sir. Fistulotomy or excise the fistula tract
Yeah, we'll excise the
with
fistula tract. We will go for the excision of the invalid bowel, and we will make a stoma for the delayed reversal and anastomosis later on. Okay. So now,
yes.
uh, I think these were the questions that we discussed. Let me check other questions. Uh, yeah, that's it. Okay, we discussed the whole station here.
Okay, sir.
Yeah.